So I wanted to discuss motion preservation because I feel we often focus a lot on fusions, and preservation of motion should always be the first line of reasoning when feasible in any patient that we treat. Something that we often might forget. These are my disclosures. So I want to thank Josh Alexa. He's my PGY7 in the audience right now. Some of these slides are his. He actually gave a talk on motion preservation last year. It was an excellent talk, and some of these slides are quite relevant to this topic. So we start out with our normal anatomy of the cervical spine. It's a very dynamic part of our anatomy, very responsible for our day-to-day life and activities. And so you can see when you sacrifice some of these motion segments, it has a severe impact on the rest of our body. So you can see the extent to which we have motion. You just look at that lateral radiograph and see how much extension is feasible. This is a table showing the normal ranges of motion of the cervical spine. So it's a substantial part of our body that's when we start fusing and sacrificing these motion segments, it really creates a stress on everything else. So the anterior approach for the cervical spine has been well established and pioneered by Cloward and Robinson, Smith and Robinson. In 1958, there were two papers that were published, and Ralph Cloward was in the Journal of Neurosurgery, and Smith and Robinson was the Journal of Bone and Joint Surgery, and both in the same year discussing anterior cervical discectomies and fusions. So you can see the anterior approach is well established. So while ACDF is the gold standard to treat anterior disc pathology, arthroplasty has become increasingly popular, and we're going to go through various different pieces of the literature. But first, we'll look historically where arthroplasty first came into our thought process. The Fernstrom ball, described in 1966, was an early attempt at trying to maintain motion. And we can see we still maintain some of that concept, the ball that and the ability to rotate and flex and extend. That geometry still is maintained in our arthroplasty options today. You can see right here, that's essentially a ball and socket joint for a lot of these devices. So not too dissimilar from the Fernstrom ball. So not everyone is a candidate for arthroplasty. You can really only consider arthroplasty for patients with 1 or 2 level disease, patients that still have maintenance of motion, patients who have relatively preserved disc heights, patients who have relatively normal sagittal alignment, and arthroplasty candidates traditionally are patients who have less disease than fusion candidates. In the setting of tumor, trauma, instability, infection, kyphosis, deformity, severe ankylosis, or severe disease of the facet joints, fusion becomes more of the choice. However, with time, there may be some opportunities to push the limits of arthroplasty, and I'll go through a couple cases to describe that. So with arthroplasty, it's important to have very good fluoroscopy. You want to be able to see your anatomy very well, because the positioning of the implant becomes more relevant than a fusion, because you really want to make sure things are centered and things that the axis of rotation is appropriate for the level that you're treating. Um, Going through some of the clinical trial results comparing arthroplasty to fusion, you can appreciate that arthroplasty often shows favorable neck disability indices and favorable reoperation rates. So these are various clinical trials uh, with 2-level and 1-level results. This one happens to be the MOBC. This is a 48-month follow-up. Reoperation rate was 4% versus 15%. Uh, and higher patient outcome scores. Another study, 5-year follow-up, similar reoperation rates, 4% in the arthroplasty group versus 16%. It's again further evidence to support that arthroplasty had a reduced rate of secondary surgeries when compared to fusion within a certain time period. This is 10-year data published in 2019. The reoperation rate was 4.7% in the arthroplasty group versus 17% in the ACDF group. So there have been quite a few studies that demonstrate this difference between fusion and arthroplasty, and these studies happen to be industry-funded studies. So that's often a critique of the arthroplasty literature, but it does make intuitive sense that maintenance of motion, when feasible, can have a positive impact on the adjacent segments, and that's exactly what the papers show. Looking at it from a different perspective in terms of cost utility, there is a incremental cost effectiveness ratio that shows that arthroplasty is more cost effective than fusion. This primarily has to do with the reduced reoperation rate. Another evaluation of cost effectiveness from a retrospective analysis of the costs of the Blue Health database, just showing that there's a reduced cost in arthroplasty when compared to ACDF. Even in the case of 2-level arthroplasties, where arthroplasties are more costly from an implant perspective when compared to ACDF, it still has a acceptable and reduced cost effectiveness status. So the incremental cost effectiveness ratio is still palatable even in the setting of 2-level arthroplasty. This is a JAMA study. When looking at the workers' comp population, this is evidence to suggest that the return to work is different in the arthroplasty group, and the neck disability index is improved in the arthroplasty group. So there was a trend towards, even in this difficult to treat population, of enhanced results in arthroplasty. So going through a couple cases here, this is a patient with both C5 and C6 radiculopathies. As you can see, there's maintenance of motion at 4-5. However, 5-6 is somewhat ankylosed. So in some settings, this might be a patient that would be a 2-level ACDF, and certainly there's nothing wrong with that. But with her young age, I thought she could potentially benefit from arthroplasty. She ended up getting a 2-level arthroplasty, and this is I actually have 10-year follow-up on her. She still continues to have normal motion at those levels. She developed an adjacent segment problem about 8 years later, which required a fusion. since once you have two levels of arthroplasty, you can't do a third level. The insurance often won't cover a third level. That's her. Despite the fact that the 5/6 disc space was more ankylosed, I was still able to reintroduce motion there, and she had some resolution of symptoms. This is a 31-year-old male with C6 radiculopathy and some element of hyperreflexia. You can see a little bit of cord signal within the cord. But again, he's a 31-year-old. So I toyed and thought arthroplasty versus ACDF. And given the youth, I erred on the side of arthroplasty, even though this may be controversial. He ended up having this implant. This is the ProDisc. This implant has the greatest amount of stability in comparison to all of the arthroplasties. There's the least amount of lateral and forward translation. So I thought someone who has myelopathy, if I'm going to do an arthroplasty, it should be the most stable implant. And so that's why I chose this for this gentleman. And he's about 12 years out. He's doing well. Never needed any adjacent segment procedures. This is a gentleman, a 46-year-old, with pretty severely collapsed disc spaces, but very much desirous of motion preservation. And so I had a tough time with this one, and it was the patient that kind of swayed me into the arthroplasty direction, but this classically would be a fusion patient. He did have a significant amount of arthritic disease. The facet joints were not terrible, but very severe disc space collapse. Almost complete ankylosis of the disc spaces there. So this was kind of different in terms of this patient being an arthroplasty candidate, but we still tried it. And managed to get implants into him, and he has the ability to flex and extend. We improved his range of motion by doing the arthroplasty and had resolution of his radicular symptoms. However, he did require an additional posterior foraminotomy because around 6 months post-op, he ended up redeveloping his radiculopathy. I think the original distraction from the arthroplasty was lost with a slight amount of subsidence. And that slight loss of the distraction resulted in redevelopment of the foraminal stenosis. After foraminotomies, he's back to square one and is quite happy and has maintenance of his motion. So arthroplasty is not without its set of complications. You can have instability that can develop. I think instability often develops as a result of over-distraction. You can have heterotopic bone formation causing cord compression. You can have spontaneous fusion. You can have subsidence if you don't maintain the intactness of the end plates during the preparation of the inner body space. So arthroplasty is definitely is not without complications. So other potential options in terms of the world of motion preservation. This is not common, but the anterior foraminotomy is described in the literature. I think the main risk with anterior foraminotomy is the proximity to the vertebral artery and the risk of injury. This is not a common procedure and should really be carefully explored in the hands of experienced surgeons. It's possible, perhaps, with the endoscope, maybe this could get revisited. But I think it should be reserved for the hands of people with great experience. There's a high reoperation rate in this series. So, I don't think it's necessarily the way to go. So we must not forget about the gold standard from the past, a foraminotomy. Foraminotomies, a very powerful procedure, especially for patients with severe disc space collapse, where they have not so much neck pain, but mostly radicular pain. We should not forget about the fact that a foraminotomy can help these patients quite substantially. Um, in addition, you can also gain access to lateral disc herniations through this approach. And so Dr. Jane had a large series of these, and the success rate was very high. Just going through the procedure, you make a small window overlying the lamina and the medial aspect of the facet joint. Often these patients who, if they have unilateral disease, I favor foraminotomy, where they have, or unilateral symptoms. Sometimes you can trim a part of the pedicle in order to improve the space for the foramen. So that's not an unusual thing to do in the setting of a foraminotomy. And the results can be very, very substantial and elegant without the sacrifice of motion. So this is a small video here, a short video just showing the technique, drilling through the medial facet as well as the lamina. You can appreciate getting in, exposing the thecal sac, getting through the ligamentum flavum. And as soon as you get through the ligamentum flavum, you start to see the epidural venous plexus pop out at you. The goal is to really control that epidural venous plexus early before it starts bleeding a lot. As you can see, there is a good amount of bleeding, but you really want to get through that epidural venous plexus in order to adequately decompress that nerve root. You can appreciate the nerve root is basically at 12 o'clock right there. And I'm breaking through the epidural venous plexus with this nerve hook and just coagulating as needed. And ultimately, the goal is to be able to put a Woodson into the foramen to verify satisfactory patency of that foramen. And that's basically a foraminotomy. It can be a very quick and efficient procedure for a patient with unilateral radiculopathy, but with enough degenerative changes that you can't do an arthroplasty. So this one is a video that looks at a patient who had a foraminotomy for a posterior disc herniation. So you can see, you can manage to get a very substantial disc fragment out. You see how large that is. This was a case that my partner, Dr. Crandall, did with Josh not too long ago. I think this was about a month ago. And Ken did me the favor and took a video of the microscope while Josh did the surgery. So bottom line is motion preservation should always be something that we should think about. The final couple slides are going to be on laminoplasty for patients with multi-level disease with some degree of myelopathy. Laminoplasty is a motion-preserving surgery that can often treat myelopathy if the patient has preservation of lordosis and has minimal neck pain and mostly myelopathy. Laminoplasty is an option. I've even found patients who have some degree of radiculopathy may still benefit from laminoplasty if they have both radiculopathy and myelopathy. Even if you don't do foraminotomies, often the radiculopathy goes away. I look at laminoplasty as a tool to address multi-level disease. And let's say even if they have one area of persistent radiculopathy afterwards, you can then do an ACDF on that one level but you've preserved motion at multiple levels, and you save that patient from getting like a 4-level ACDF to maybe a 1-level ACDF with a posterior laminoplasty. So that's how I look at laminoplasty. It's an opportunity to save that patient from getting a 4-level ACDF, which ultimately will result in a C2 to T2. So there are a couple of different ways to do laminoplasties, but I'm running out of time here. But bottom line is, I think there are a variety of ways. There are a variety of ways to preserve motion, and you can be creative about it, and potentially save the patients from having a multitude of fusion surgeries, down the road in their life. Any questions? Yeah, go ahead.
Dave McCarthy from PGY5 at UPMC. 2 questions. Do you ever consider doing an adjacent level, someone who had a prior ACDF with an arthroplasty?
Yeah, I've certainly done that before. Arthroplasty adjacent to a fusion. My preference is to do the arthroplasty above the fusion and not below, because I feel like if the fusion is above it, it may overburden the arthroplasty. That's just my overall interpretation. I've done that before, where the patient has had a fusion and have done an arthroplasty above it. But I would choose the most stable version of the arthroplasty, which in my opinion is the Pro Disc.
And then the second question is, do you have an experience with like MIS laminectomy in the cervical spine at all?
I'm sorry, say that again.
Have you done any MIS laminectomies in the cervical spine?
Yes. Yeah, through a tube. Yeah, yeah, just like foraminotomies can be done through a tube without a doubt. Definitely.
Let me ask a question. Who here in their programs, by show of hands, routinely does ADRs in the cervical spine? Just show of hands, routinely. Who has not done an ADR in the cervical spine so far? Couple, wow. Who's done lumbar ADRs? Just out of curiosity. Anybody? 1 or 2? Wow. Yes. It's actually so you're a leader in neurosurgery. What's going on? I mean, this is I honestly, and I'm going to ask a follow-up question, superior surgery, all things being equal to fusion. I stay with my concept of true minimally invasive surgery is not the amount of skin or soft tissue dissection, it's motion preservation if feasible, mechanically, physiologically, neurologically. So who, if you had a 5-6 disc herniation, this is no bias here, would prefer an ACDF over a disc replacement? Who would have a fusion? Anybody? Who'd go for a disc replacement? Show of hands in reverse. Right? It's not even a question anymore. Where's this mismatch coming from? Is it financial incentive? Because we do get paid a heck of a lot more. Industry gets paid royally more for fusion. And why don't we do more? Let me ask the same question for laminoplasties. Who's done routinely laminoplasties? It's actually, that makes me happy. Easily have. Again, an example for a vastly under-reimbursed surgery. Is that the problem, or is it too technically difficult?
Yeah, I think it's a combination of things, but like everything in life, it's multifactorial. Certainly one consideration is the finances, but I think the second consideration is the speed, of the surgery. And an arthroplasty is a more demanding procedure. It requires very good precision to be perfectly midline, very good fluoroscopy. You're making these keel cuts very often. There are a few extra steps there. There's a risk of residual pain in the setting of radiculopathy for patients who have foraminal disease. I think it's just very common to not be a perfect candidate for arthroplasty and therefore just be thrown into the realm of fusion just because it's just, you just don't have to think about it as much. Fusion is more forgiving. You can be off center and still have a fine outcome. You can do an inadequate decompression and still have resolution of symptoms. So I think fusion is easier on the surgeon. Unfortunately, it's not easier on the patient. So it's one of those dilemmas that we have. It's more of a guarantee in terms of good outcome But you really have to be, I think, very careful with your arthroplasty patients to do a very thorough decompression if you're going to have success. And I think, again, foraminotomy, I put those videos of the foraminotomy because I think it's an underutilized procedure. And if the patient has unilateral symptoms, one should consider a foraminotomy.
Charlie, that's a great talk, and I appreciate everything that you said. I'll go right to the one case that you showed of the guy with bone-on-bone discs, and some of the little caveats from things. I've been doing these things. I was a big foraminotomy guy, laminoplasty guy. Been doing artificial discs this year for 20 years. We ran the first trial. I think you were involved in that trial also, started in 2004. I've tried to convert all of my practice into artificial discs, and it's about 50%. And I do 2, 3, 4 level cases with frequency. We battle to get them approved, but cases that I think need them the most are like that one guy that you showed with the bone-on-bone discs.
Right.
And we spend a lot of time loosening up the oncovertebral joints. We will go around and I'll take a curette around next to the vertebral artery. I'll loosen those up. And it's restoring motion in those, because if you just go put an arthroplasty into a partially arthrodeced segment, it will go on an arthrodeced. It'll fail. And so that's something just over the past 10 years that I've been doing that, is that we mobilize people. In fact, there are some people we operate on purely for mobility problems. Okay, my PA's husband, okay, he said it in public so many places, but he's a hand surgeon. And he said he couldn't see his TV because he's a big sports guy and he loves to watch. He has a floor to ceiling TV. He couldn't see the top of the TV. And he came to me, he says, my neck's going stiff. I can't do anything. He had one fused segment that I couldn't do anything about. I put I put prestige in people. I call it the old guy disc. And I think it has even less mobility when it comes to a hard stop from that ball and trough. But it's the mobilization, it's the decompression, and you're absolutely right. You have to be a better decompression surgeon, because if you don't go clean out those foramen all the way out, the patient won't be happy. In fact, you might even make them worse.
Mm-hmm.
And I've done foraminotomies in those. I do fewer foraminotomies, and sometimes we do them from the front too. We will go through around the oncovertebral joint and drill it down with the old Joe procedure, which I did and published on. But it's not the future. It's here now, is what I think. In my practice, it is. I mean, in 3 patients, I put in 9 cervical artificial discs this week.
I think for the younger generation, you want to market yourself. You want to be successful in your local markets. MIS is obviously a patented tool, and having a robot in your office is cool. But tell them you're doing motion preservation, way better, truly minimally invasive, truly physiologically less invasive. And people like that. And they now know that they're wisening up to that. They want fusions, right?
A couple more points, a couple other things. The patients go home the next day. You don't have to wait for a fusion. You don't have to put a collar on them. And I tell them, what do they do with their neck? I say, just use it in whatever way you want. And when can you go back to work? Next week.
Yeah, I agree. I mean, I think it's a liberating surgery. It makes a big difference in the patient. I feel like they get better faster. And it just should always cross your mind, can this patient be an arthroplasty candidate? And I would err on the side of saying yes.
And yet we have a quarterly arthroplasty forum. Dr. Johnson was one of the early adopters of the technology, and again, a frequent contributor. And it's really cool to have this kind of a national network of people who somehow really know that this is actually better. And talking about myself, I actually think that made me a better ACDF surgeon when I have to do it, because I apply the same principles: a nice release, a nice foraminal decompression, preserve the end plates, realign the spine, not just fusing, stuffing a bone graft in. So I've learned a lot from the necessity to release the anterior segment. Question to the both of you, maybe, foraminotomy. So a great another overlooked procedure. We had Tim Adamson here several times, one of the neurosurgical godfathers of scientific publications. Why is this not done more? Should we, and is there a problem with doing it at multiple levels or bilaterally? What's wrong with doing a microforaminotomy?
Yeah, and that's why I wanted to give this talk, is just to remind people that a foraminotomy is an option. You know, it's for patients that are not maybe candidates for arthroplasty, you can do a foraminotomy. I think one of the reasons why not to do it is, you know, the prone setup is a pain, you know, to get the patient positioned, and, you know, the recovery is more difficult than an ACDF for the patient. So, you know, that posterior muscle dissection can sometimes be more painful. But I still think it's an underappreciated surgery, and I'm hoping for a sort of reincarnation of that surgery.
Can I make a comment on that?
Yeah.
Let me get at the mic. So I actually had unrelenting arm pain for about a year. One night I couldn't pick my wrist up anymore. Next morning, Pat Johnson emergently did a posterior foraminotomy, 2 levels. I was in the gym 2 weeks later. So I'm a huge fan of that procedure. And I'm a huge fan of Pat.
Can I have a last comment? Not about Dave. I'm happy. Well, there was a big herniated disc with it too, but anyway. I hope that's not violating anything, but you already did you told the world already. I used to be a big foraminotomy surgeon for years and years, 20 years plus. And because we couldn't do artificial discs during the first 10 years of our experience with the whole arthroplasty thing, the last 10 years has changed. And what's interesting is all of my foraminotomy patients are coming back now and having artificial disc put in because that disc finally wore out. Dave, I think your disc is going to last a long time. It looked okay. But, you know, so I've moved away from it. I used to do tons of anybody that had cervical radiculopathy, regardless of whether they had, unless it was overwhelming pain, and then I do a fusion. But I do a lot of decompressions, and they did well for lots of years. But nowadays, I think that I have replaced most of those patients with arthroplasties.
Mm-hmm.